So first-line therapy now has really evolved greatly since the first drugs, the new class of drugs for metastatic castrate-resistant prostate cancer came out about 5 years ago now. Early on, we had a very limited portfolio of medications to use in the metastatic castrate-resistant prostate cancer. As they came forward, the drugs were only initially approved, such as abiraterone and enzalutamide, in the docetaxel failure space. Now, of course, as the new trials have all come out, we now have the ability to use drugs like abiraterone or enzalutamide, which are FDA label approved for use in the pre-docetaxel space. So what this has really done, it's really opened up the horizon for the individual choices that an oncologist has in choosing the initial therapy for patients with metastatic castrate-resistant prostate cancer. Interestingly, all of the guidelines still cover second-line hormonal manipulation, particularly if you look at the NCCN guidelines and you look at the really the ASCO guidelines and the AUA guidelines. They actually do talk about agents such as ketoconazole, such as nonsteroidal anti-androgens, and using them. However, what's nice about the guidelines is they also note that these are probably not the best agents to use and may not be durable. So, kudos, so to speak, to the guideline writers to saying, yes, if you're really stuck, you can use these drugs, but you have to be honest between you and the patient, they may not give you the same durability. So what's nice now is that we have many drugs available to us, both pre-docetaxel and post-docetaxel. We have to remember that was the only real FDA-approved drug that it goes back to 2004. And yes, people might argue that mitaxantrone was approved before then, but it was really only approved for palliation. So from 2004 until almost 2009, 2010, the only FDA-approved drug we had for metastatic castrate-resistant prostate cancer was docetaxel. And now, of course, we have enzalutamide, abiraterone, cabazitaxel, radium-223, sipuleucel-T, a whole new package of drugs available to us. So concerning the first-line therapy, a few other comments. We now know that radium-223 is really good in the setting of painful bony metastasis. We know that sipuleucel-T really should be used at the earliest stages of metastatic castrate-resistant prostate cancer before patients become symptomatic. So these first-line decisions now really have to be very carefully evaluated, and the appropriate agent needs to be used in that setting. For example, if someone has narcotic-dependent, widespread metastatic castrate-resistant prostate cancer, sipuleucel-T is probably not an appropriate choice for that patient. However, radium-223 may be a reasonable choice, particularly in the setting of painful bony metastasis. So for radium-223, it's really not on there for a specific pain indication. That's not what radium-223 is approved for. It's approved for metastatic castrate-resistant prostate cancer. However, if you look at the studies that have been done, if you look at the pain scores, it does give patients significant relief. So although it's not in the package insert, a lot of physicians do choose it for patients who have more painful bony metastatic disease. Again, that's not to say it's the only choice in that setting, but it is something that often is chosen by medical oncologists to treat these patients. And lastly, if you look at the guidelines for patients with painful bony metastatic disease, sort of spot radiation is also something that should be considered in patients who are having significant bone pain.